pregnancy-induced hypertension, and we will discuss the etiologies and risk factors. Even the clinical management of chronic hypertension, preeclampsia and eclampsia. In a chronic hypertension, as any other hypertension, you know that the systolic blood pressure has to be 140 millimeter of mercury and the diastolic has to be 90. If we have got two same findings, same raised blood pressures, 4 to 6 hours apart, then we label them patient as a PIH. But in a chronic hypertension, the patients are already a hypertensive when they enter into the pregnancy. Even these patients, when they enter into the pregnancy, the blood pressures remain at the level of 140/90. You cannot bring them down to 170 or 80, and that is even not our aim to do it, because their blood pressures are already high and they've been set on a high blood pressure. Then there is the severe blood pressures, means that while they are already towards the higher level, but even the blood pressure rises further from 140/90 to 180/110, then it is a severe one, and we need to add more antihypertensives, and they need a definitive treatment. We use antihypertensive drugs in this pregnant in their with the patient with chronic hypertension, but as you know that already on antihypertensive drugs, which we need to alter it and change it, and then see that which type of which group of antihypertensives they are taking. So we have to change accordingly as soon as the patient gets pregnant. And these are the patients who will show up with a high blood pressure even before 20 weeks of gestation. As we know that pregnancy-induced hypertension occurs when the patient has got, when reaches up to 20 weeks of gestation. And these hypertensive, the chronic hypertension patients, the blood pressure even persists postpartum. In a normal PIH, the high blood pressure does not persist. It usually finishes within 6 weeks of pregnancy, but in the patients with chronic hypertension, it persists even after 12 weeks of pregnancy, of their delivery, sorry, postpartum. Then preeclampsia. What we do in this preeclampsia, just you have to remember there's a triad. Hypertension is there, but along with that, the patient has got proteinuria and edema. Edema is not very specific component, because edema usually occurs during normal physiological finding of the pregnancy as well. But even if a patient has got preeclampsia, you will find cross edema and proteinuria. Because of the proteinuria, the edema is more significant. But it is not considered as a required component of it, because it is a physiological part of pregnancy. In mild preeclampsia, that is all above all these, and the blood pressure only rises according to mild, moderate, and severe. But you have to remember that it is proteinuria and edema, which is a non-dependent edema. In severe preeclampsia, the blood pressure is extremely high, that is 160/110 or any reading above that, and the proteinuria is 2 plus dips or more than 5 grams of protein. You do a dipstick, you take a urine DR, you see the collection of the proteins in that, then you will find that if it is 2 plus, that it means that patient has approached from mild or moderate to severe preeclampsia. These patients can also present with headache, visual disturbances, epigastric pain, and even decreased amount of urine is passed. So if a patient is not admitted and comes to you in a clinic, then you have to ask them about that if they go for their urination, is it adequate or not? If it is not adequate, then you have to immediately ask the patient to get admitted. Then the patients can also present with HELLP syndrome, and sometimes they present with fetal growth restriction. In eclampsia, that is the next step of this. What happens if the preeclampsia has not been controlled? Then the patient can have a seizure, and that can cause a significant activity which is related to their central nervous system. But if a patient has a seizure, we have to differentiate between a seizure, and the other abnormal and the other signals of the seizures, like if they are caused by epilepsy, meningitis, or mass lesion, or any other hemorrhage. So you have to differentiate at that time whether this seizure is due to eclampsia or is there any other cause. It is one of the associated causes of the maternal deaths, and it is 10% of the total deaths if a patient has gotten eclampsia. The incidence of eclampsia is 12 to 20. The incidence of hypertension is 12 to 22% of the pregnancies which are affected. Are affected. 5% are only chronic hypertension, and 5 to 8% leads to preeclampsia. And out of these 5 to 8 preeclampsia, only 10% of them develop eclampsia. It is not that every patient who gets a high blood pressure will have a fit or will have an eclamptic fit or seizure. The risk factors are nulliparity, a patient with a previous history of preeclampsia. In a primary patient, if they have got a strong family history of hypertension or preeclampsia, then we have to be very careful about these patients. Those patients who have got a chronic hypertension and they get superimposed preeclampsia with a chronic hypertension, then definitely these patients are a higher candidates of having eclampsia. Diabetes mellitus, not a recent diabetes mellitus, long-standing diabetes mellitus leading to vascular abnormalities are more prone to this. Patients with renal diseases, because these all lead to the hypertension. Even connective tissue disorders like APLA positive patients, the lupus anticoagulant positive patients, patients with multiple gestational pregnancies, patients with hydatidiform mole can also present with preeclampsia or high blood pressures. Certain fetal anomalies, age more than 35, of course, they are more prone to have high blood pressures. As we know, what is the pathophysiology? It is not exactly understood, but the thought process is that if there is an inadequate invasion of the trophoblast into the myometrium, which leads to the lack of invasion and allows the myometrial portion of the spiral arterioles to maintain the muscular walls, preventing development of the normal low resistant uteroplacental circulation. Because there once the pregnancy and the placenta is implanted, the resistance between the vessels is very low. But if the invasion is incomplete, then it leads to the vasoconstriction and later on leading to the high blood pressure. Increased vascular reactivity, and there is increased platelet activation, and these altered prostanoid balance favors to the production of thromboxane A2 and prostaglandin F2. And these two are the ones which cause vasoconstriction and platelet aggregation. However, there are other prostaglandins as well, like PGI2 and E. They are the vasodilators. But the PGF2 and thromboxane A2 are the ones which are the positive factors for the vasoconstriction. There are alterations seen nearly in all the systems of the body. If we go for the hematological side, the platelets are very low. The patient can have hemolysis, increased platelet activation, and even in the cardiovascular, there is vasospasm, there is hemoconcentration. When it affects the renal, the patient starts making less urine and start throwing protein, so it can lead to acute renal failure and ATN. In the liver, the enzymes are altered, the LFTs will be altered, and her transaminases means SGPT will be high, bilirubin will be high, and the patient can have a hepatic hemorrhage even. Even in the neurological, because of the edema, because of the excessive fluid in the body, in the third space, the patient can have headaches, scotomata, blood vision, hyperreflexia, temporarily even blindness can occur because of these high blood pressures and seizures. The fetus is also affected with this. If it is a long-standing, then the patient can present with long-standing hypertension, and the patient can present with intrauterine growth restriction. oligohydramnias, even abruption because of high blood pressure. The ABGs can be altered once the babies are delivered, and the CTGs, if we do it, they are very non-reassuring with the significant high blood pressures. There is a complication other than eclampsia, which is as HELLP syndrome, which also occurs in 20% of the women, and it is usually seen in patients with severe preeclampsia. HELLP usually cannot occur; it can occur individually as well, but usually the patients with preeclampsia show all these abnormalities, and it is more commonly in multi-gravid patients. In HELLP syndrome, the H stands for hemolysis, EL for elevated liver functions, and LP stands for low platelets. If we need to evaluate a patient with a chronic hypertension, yes, all the baseline investigations, but you need to know the reason for blood pressure, high blood pressure. It could be due to any medical etiologies, which is pheochromocytoma or Cushing syndromes. And even in the pregnancies, if the patient with a chronic hypertension gets pregnant, then we should have an echo done to see the status of the heart, whether there is what is the ejection fraction, and because of that chronic hypertension, what is her status of the ventricles, her ECG, and in the long-standing diabetic patients and in the long-standing hypertensive patients, in both the patients, we should advise for the ophthalmologic examination. In preeclampsia, the serial blood pressures are done. If a patient is in the hospital, we do it every 4 hourly. But if the patient is at home, and then you have to ask them to bring a chart of the whole week, how the blood pressure has been at different occasions. We ask them for urinary protein excretion. Fetal monitoring is required, the fetal movements, or if the patient presents to you in the clinic, then we have to do serial ultrasounds, per abdominal examinations to make an assessment of the fetal growth. To rule out HELLP, you need to send a CBC, a complete blood count, in which the hematocrit is extremely important because these patients uh, they have got water depletion and they've got a high hematocrit. The platelets will be low in a patient with HELLP. The uric acid will be high, and if you get an LFTs done, the SGPT will be significantly high, and uh, LDH is also sent, lactic dehydrogenase, which is LDH is always very high and raised. If the LDH is more than 600, then it means that the cause is her preeclampsia, and which is causing this LDH. Because during this pregnancy, the patient can present with other liver disorders as well. But if the LDH is more than 600, then it is more significant that it is due to preeclampsia. In the How do we manage a patient with all different chronic hypertension and preeclampsia or HELLP? If a patient is with the chronic hypertension, we generally deliver at top because their body is or prone to manage with a high blood pressure that is up to 140/90 or up to 140/100. That is also considered as normal because we continue monitoring them, and at a safer time when they reach term, that is 37 weeks or 38 weeks, we deliver these patients. Unless they have superimposed preeclampsia or HELLP syndrome, then we have to make a decision at whatever time where the fetal maturity is achieved, and then we deliver the patients. If a patient has already been taking ACE inhibitors initially, so you have to ask the patient to switch over to more safer antihypertensive drugs, which we will discuss later on. And because these ACE inhibitors cause renal failure and they are teratogenic, they cause oligohydramnias and pulmonary hypoplasia in the fetus and severe IUGR. And even if etanerol taken for a longer time, it also causes IUGR. In the preeclampsia, if needed, if a patient does not have a seizure, it is fine. But if the patient has got hyperreflexia or the reflexes are brisk, then we we give the prophylaxis for seizures, that is magnesium sulfate. We control the blood pressure, and once the patient is managed and the element of prematurity is not there, so we deliver the patient. In the pre-eclamptic, the term delivery, it is a short-term goal. We usually try to take it to term, whatever time, whatever appropriate time of delivery that we can find, where the baby is mature enough, can be delivered, and does not have the perinatal morbidity. So that is the time where we have to make a decision and weigh the benefits between the delivery and for continuing the delivery. So that's a very vague treatment that we can say here. The only thing that you need to say that is that once there is a preeclampsia, we try to take the patient up till term if possible. If not possible, then we stabilize the patient and deliver at an appropriate time. If the patient is every hypertensive or every preeclamptic patient never ends up into a cesarean section. So please do not write this that if a patient has a preeclampsia, we will deliver the patient by a cesarean section. It is a decision made at that time according to the gestational age of the baby and according to the weight of the baby, whether it is appropriate to give a, whether the baby can sustain the trauma of the birth canal, or the patient needs to be delivered by cesarean section. In mild preeclampsia, the expected management, you observe the patient, do a close maternal and fetal surveillance, and take up till whatever better time that we can get. 34 is the first cutoff where we get it, and 37 is a very good time where you can deliver the baby and we can have a good perinatal outcome. The ability to intervene either if conditions worsen or acceptable, that is all according to the individualized patients. The decision is very individualized. In severe preeclampsia, it is very controversial. Sometimes delivery for poor maternal condition is likely to be done over the short time. For example, if a patient presents to you at 30 weeks and the patient has got severe preeclampsia with high reflexes and she's showing the signs of HELLP, or her liver enzymes have started deteriorating and they have been altered. So that is the time where we have to weigh and balance between the mother and the fetus, and as we always say, that mother is always on priority. Uh, Expectant management is for very selected patients, just to reduce the perinatal morbidity and mortality due to prematurity. In preeclampsia, the patient needs, in a preterm, in a severe preeclampsia, patient needs hospitalization, magnesium sulfate for seizures, not for blood pressures. The blood pressures are maintained to a normal level, that is up till 140 or 90 it is. To control that, we do not need a very tight blood pressure control, because very tight blood pressure control can also lead to hypoxia in the fetus. If a patient is admitted, then the daily assessment by a fetal kick chart, CTG, or by doing an ultrasound, Doppler, or even a biophysical profile is also advised when we have a very close surveillance of the patient. In a very preterm, whereas it is 24 to 34 weeks, steroids for fetal lung maturity are given, and the ongoing surveillance is stable. 33 to 34, then give they give them steroids and then deliver within 48 hours of the steroids. For a HELLP syndrome or a severe headache or uncontrolled hypertension or eclampsia, you need to deliver. This is the criteria where you can have the delivery within 72 hours, where a patient has got uncontrolled. These are the things that you should keep in mind, because we cannot compromise a mother for the sake of prematurity. But if a patient has got uncontrolled blood pressures, means 160, 100, 110, and you have given all the hypertensive, it is not coming down to 140, 90, then that is the point where we cannot take a risk for the patient, because the chances of abruption or hemorrhage is high, or the patient has already got a fit, she has already come with the seizures, and you have made a difference between an eclamptic seizure and an epileptic seizure. Platelets are very low, or the AST or ALT are 2 times in the upper limit. Pulmonary edema or signs of renal failure when the patient presents with oliguria or abruption, of course, then you have to deliver immediately. Expected management is when there is a controlled hypertension, urinary protein is not high. Oliguria means there is less urine, but still the patient is making urine up to 20 to 30 ml, then it is fine. Uh, and LFTs are more than 2 upper limit, but no epigastric pain or no right upper quadrant tenderness. Magnesium sulfate is the choice of the treatment for eclampsia and seizures. It raises the seizures because magnesium sulfate helps the patient in controlling the seizures. It has a direct vascular relaxant effect, but it is not an antihypertensive. Do not consider as antihypertensive. It is completely for the seizure control. It can be given IV or IM. 6 grams is the loading dose by 2 grams per hour. Then the therapeutic range goes from 6 to 8 milligram per deciliter, and supratherapeutic level leads to, for example, if you have given a patient a loading dose and then you're keeping them on the therapeutic or by an IV injections, then you have to be very vigilant about the different symptoms, the different signs that can occur while giving a magnesium sulfate, which is the CNS depression or the cardiac arrhythmias, or possible cardiac arrest can even occur if the magnesium sulfate toxicity occurs. So you have to see the patient's plantar reflexes, you have to see a respiratory rate when you are given a magnesium sulfate. It has to be given in a high dependency unit. Very careful, monitor the patient, look on the monitors, keep her respiratory rate normal, keep an eye on her oliguria. If the urine output is decreased, then you have to either decrease the dose of magnesium sulfate or even stop magnesium sulfate, whether the patient has had a fit or not. But if the patient is not making urine, we cannot give magnesium sulfate because it is nephrotoxic and it has a renal excretion. The antidote for magnesium sulfate is calcium gluconate. The aim of magnesium sulfate that it should be continued till 24 hours after the last fit. Even if the patient has delivered and she has a fit, then you have to continue magnesium sulfate till 24 hours after the last fit. In the antihypertensive drugs, they need it persistently. Antihypertensive, if the blood pressure is more than 160, 170 or 100, that needs treatment. The only goal is to bring it to 140, 95 or 150, 100. But you don't have to bring it to 170 or that, because as I told you earlier, that it causes the underperfusion of the uterine artery leading to fetal bradycardia, and you can have a bradycardia on the CTG while the patient is admitted. Methyl dopa is centrally acting. Well, these are the drugs that we can use and are safe during pregnancy, and a combination of all these 3 and 4 things can be given. The patient can be kept on methyl dopa. If not controlled, you can add labetalol. If it is not controlled with that one again, then the third line you can add hydrolysine, which is a direct arteriolar relaxation. Then you can add nifedipine, which is a calcium channel blocker. Yes, it can be used, but it can have a synergetic hypotensive effect and negative inotropic effect with magnesium sulfate. So as the 4th line, you can give them nifedipine, but we have to be very careful along with that. The antihypertensives which are completely asked to avoid is ACE inhibitors, because it causes both fetal renal failure, and it is teratogenic, so it should be stopped immediately. Diuretics are avoided because it reduces uterine perfusion, and angiotensin receptor blockers are also not allowed, and the calcium channel blockers except nifedipine The other calcium channel blockers should not be used. A patient with eclampsia, what happens in that? There's a typical seizure. How it happens? It happens for approximately 90 seconds, 75 to 91.5 minutes, with two phases where initially the patient has got a facial twitching progressing. If you're standing there, you can find this. The patient has a facial twitching progressing to the generalized rigidity, then 60 seconds of tonic-clonic activity. Segmental constrictions and dilatation of the cortical arterioles lead all to the decreased perfusion and cerebral edema. Reduced breathing and fetal bradycardia also occurs at the same time. And this is a very typical eclamptic seizure, which is different from the epileptic seizure. And the treatment immediately do your ABC, that is protect your airway. Position should be left lateral. Prevent so that the patient does not aspirate, and it also helps in uterine perfusion because of the gravid uterus. The uterine perfusion will also be low if you keep the patient in a straight position. Prevent injury means injury of the tongue, or the patient can fall down from the bed, so you have to raise the sides of the side angles of the bed so that the patient does not fall down from there. Oxygen inhalation is required, and seizures to be given after seizure has been terminated, because while the patient has got a seizure, you are going to manage with the ABC. With the recurrence in the preeclampsia, yes, these patients have a recurrence in the future. If patient has got once has a history of preeclampsia, then they can have it again. Increased lifetime, because these are the patients who are more prone to enter into chronic hypertension. They have got an increased risk of preeclampsia in their family as well if a patient has got a history. Baby aspirin can be used. It protects up to 10%. It is not proven, but it is given because it gives a benefit to the patient. Then calcium carbonates. They say that if you give calcium carbonates initially from the pregnancy, then again it helps in preventing preeclampsia. Antioxidants like vitamin C, E, they are promising, but still the RCTs are not performed. But baby aspirin and calcium are the things that we keep them giving from the very beginning. All right. Thank you very much.